should know that because that is something people like to put on tests. There are cartilage, ligaments, and joints. Objectives. We don't need those, we don't need that, we don't need this. Although bones are composed of non-living things, like calcium and phosphorus, they are living tissue. It's very reminiscent of the skin. We have skin that is living tissue, which means it requires blood supply because it has to have nutrients. But there are skin cells that eventually lose their nucleus and build keratin, of course, and become solid. So we have bone cells that are very similar that way. These are living tissue. These bone cells are living tissue that require that blood supply. This is a good thing to remember as a paramedic, because when you see a fracture, especially a compound fracture, where the bone has been torn through the skin, but you're familiar with the term compound fracture, okay? If the bone is broken through the skin, if it's displaced that much, that means it's probably pulled away from blood supply, or some blood supply has been pulled away, which means some tissue is not getting blood, which means it's not getting nutrients, which is going to increase the potential for necrosis. You'll notice the bones are deep. There is a bunch of tissue that surrounds this bone. That means the body isn't as concerned about a pathogen invasion here as it is here. Our skin is exposed to the outside world. This is what's going to have the abrasions, this is what's going to have lacerations, what's going to get cut, this puncture, whatever. This is where we are going to find the most potential for pathogen invasion. By the time we get here, our immune system should have stopped anything. Our skin should stop most things from getting in. But if something does get in, we have an immune system in our skin that should stop most things before they get too deep. The deeper you go toward the bone, the less immune response, which means this area is very susceptible to infection. Something else to keep in mind. I understand that as a first responder, you're going to be there to stabilize and transport. But I still want you to understand that the way you stabilize things, the way things are going to end up, makes a big difference later on. Word skeleton comes from Greek. Dried up body. That's what it looks like. Bones are classified according to their shape. Long bones are just that, long. Short bones are short. Flat bones, this is going to surprise you, are flat. And irregular bones we'd find something like in the hand and the hip. The vertebrae, you can see a good image of them here. Posterior. All right. You see a posterior view of the shoulder, the right shoulder. The periosteum is a membrane that surrounds the bone. You've probably seen this before if you've eaten turkey or chicken or something. We get down to the bone, there's a thin membrane that covers the bone. You can kind of peel it off a little bit. This is important to help maintain the blood supply. In other words, it helps to sort of direct blood vessels, keep them in place, offer some protection. It'll keep lymph vessels and nerves in place as well, and acts as a very important anchor for things like ligaments and tendons. If you look at a long bone, like on, I think it's the third page. Okay, yeah, if you look at a long bone, the top of that third page, looking suspiciously like a femur, you will notice that it has this straight area, and then it has two widened ends. The straight area is called the diaphysis. The widened ends are the epiphyses, or pleural epiphysis. Have you heard these words before? Familiar with this? Someone familiar with this? Okay. The diaphysis, the straight end, is really where we find the yellow bone marrow. And the epiphysis, epiphyses plural, this is where we find the red marrow. This is where the blood cell formation is found. It is in the epiphysis we also find the epiphyseal plate, which some people often refer to as the growth plate, because this is where bone is continually be added until eventually the person stops growing. That's, their arms are no longer getting longer. Their fingers are no longer getting longer. Sorry, it's just for me, something else. Yeah.
Epiphysis, so the plural, is it just ES, or is it?
Yeah, it's ES. Okay. Epiphysis, singular is IS, epiphyses, plural is ES, SES. Right. Yellow marrow is high fat content converts to red marrow, which makes red blood cells in an emergency. How does it know how to make red blood cells? How does it know why to make a red blood cell? Any idea? You know where it gets the signal from? It gets the signal from the kidneys. If this blood pressure suddenly goes low as a result of some trauma, there's a lot of blood loss. There is a hormone released from the kidneys called erythropoietin. Have you heard of this? Erythropoietin acts on the bone marrow. It sort of tells the bone marrow to make more red blood cells. And make the ones that, get the ones you've already started to make and mature them faster, get them to the maturation stage. Because again, all of these cells that start out as hematopoietic pluripotent stem cells, once they start down the pathway to become a specific cell, it has to go through several steps, which kind of makes sense. Because if there's one cell that's going to become any kind of cell that any blood cell needs to become, it's not going to do it immediately. There's a process to it, and once it starts down that process, it won't go back. So you can see a nice picture of it's the periosteum here, wrapping around the bone. Compact versus spongy bone. Compact bone is the dense, hard bone that you would expect bone to be made of. The material, the compact bone makes these little cylindrical shaped structures called Haversian systems with Haversian canals. Have you heard of that? Or now you often call them osteons. You'll hear either terminology. Okay. I learned them always as Haversian systems, but so you'll hear me probably saying that more often. Each of these have mature bone cells called osteocytes. Osteocytes kind of makes sense. Cyto is cell, osteobone. But osteocytes work also in conjunction with osteoblasts. These two bone cells really help to make up the ever-changing landscape of bone. Just like our skin, with our skin we lose layers of skin. Of course, they flake off, they slop off, and they're constantly being replaced. Bone, in a similar way, undergoes a change. Every year, about 10% of our bone gets replaced with new bone. So it's recycled, broken down, and then new bone is built back up. As babies, we have a lot more new bone being added and a lot less old bone being broken down. In our elder years, we have a lot more old bone being broken down and a lot less bone being broken up, added up. So we're going to end up with a thin skeleton, a fragile skeleton, one that can easily fracture. As adults, we're going to have the same amount of bone replaced as bone lost. An important concept, because when we talk about the endocrine system, you'll see these things again. You'll see these osteoblasts and osteocytes again. I like to tell people that the osteoblasts are going to be the cell that breaks the bone down, builds the bone up. Osteoclasts, reverse that. Osteoclasts are the cells that break the bone down. In order to help people remember that, I say that osteoclasts collapse bone. Osteoclasts collapse bone with a C. Osteoblasts build up bone. Now, why is that important? Because when that bone gets collapsed, it's going to release things like calcium into the blood. And calcium, I just told you, is important for muscle movement. So if a person has all this bone being broken down, all this calcium in the blood, we're going to see things like cramping, fasciculations, twitches. As compared to if somebody has their osteoblasts building up all that bone, putting that calcium in, they're going to have low calcium in their blood. They're going to have muscle fatigue, for instance. We'll see this later on when we talk about parathyroid and the thyroid hormone. Have you heard of these? Parathyroid hormones, thyroid hormones, calcitonin specifically from the thyroid. Yes, no?
No.
Okay. These are the hormones that sort of direct these cells what they need to do. All right, that's what we want to know about that. There's a good picture of the Virgian there. You can see the Virgian canals with the blood vessels running through them. You can see how they also can run parallel, and the matrix of bone that builds up around them. It's interesting, it sort of folds around it. It's an interesting process of how new bone folds. Spongy bone is arranged in bars called trabeculae, and you can see those irregular holes when you look at a bone. That's why it has that spongy look to it. Bones have a bunch of things that stick out of them, things that are indented into them. They have a lot of protrusions. Some of these you need to be able to recognize by name. They're all important, however. Some of them are very, very obvious and stick out quite a bit, like this one right here that comes off of the scapula. Some of them are a little less obvious, like maybe some of the transverse processes, the little bumps off the side of the vertebrae in the neck region. So I'll let you know which ones I want you to know about. When you see a bone like this and you see a groove running up through here, understand there's a reason for that. Understand there's probably something that runs in through there. And a deep one like this, you're probably going to see something like a ligament or a tendon running up through here. Now this one actually right here, you see the bicep, the biceps. You know bicep muscle?
Thank you.
All of this again should be somewhat reviewed. Projecting structures and depressions can work together and join articulations. An articulation is a joint. All right. This is stuff that you guys are going to have to do in the field. You guys are going to have to know about interosseous injections. Now, why would we inject something into bone? If you can't get it in your vein, you got to get fluid in. There's a lot of vasculature. There's a lot of ways, a lot of good vessels that are going to soak up that fluid. Now, in what patient would you expect that to happen?
Burn patient.
Say all that again, but singularly and louder. Cardiac arrest. Pediatric patients. Probably obese, yes. Yeah, morbidly obese. Yeah.
Burn victims.
I'm sorry?
And burn victims?
Yeah. Burn victims, absolutely. Good answer.
Did you take ABLS yesterday?
Depending on what's wrong, it could be like dialysis patients.
Yeah, sometimes. Now, here's what you need to understand. And this is why I brought it up before. When you're poking this needle in, you're going deep, which means all that stuff you learned about using a sterile technique, in this case, is really, really important. Because if an infection gets in there, and there's not much of an immune response to stop it, it's going to grow and grow out of control, which means you're going to end up with necrotic bone. And when you have necrotic bone, you got to cut it away, just like any other necrotic tissue. Now we're talking like amputation. So you have to keep things like that in mind. So when you do a procedure like this, the sterile technique that you use everywhere else to put an IV in, that you might get a little sloppy with sometime, this is one of those times that you don't want to be sloppy. Lawyers call you. Well, they don't, yeah. Patients die from stuff like this. Okay, you can see it going into the medullary sinus. And examples. That's the injection gun. Sternum. And that's a nice one. Anyone ever had this done to them? Anyone even know anyone who's had this done to them? They talk about being painful, or they're unconscious at the time.
Is it common?
Is it commonly done? It's not really commonly done. It's not commonly done. And there's still some speculation with some things. And one of those things is actually cardiac patients. There's some people are kind of on the fence with it. needs to be done, if you have to get fluids in and there's no other way, then this is the way to do it.
I hear it only hurt when you flush it.
Really?
Alright. When I see the dump.
Yeah. There's a video?
There's tons of videos.
Yeah, but and do it to himself. These things not for that.
If you choose to do it yourself, you're not.
Well, not to yourself.
Right.
And I think it's
I wouldn't want to do it to myself. All right, really good terminology. I strongly recommend that you know these. But the reality is, when you start looking through a book, like this one, it makes it a lot clearer what condyle and tubercle are. This is Frank Netter's Atlas of Human Anatomy. This is a really great book. I've told you before, this is the book that is in every single medical school on the planet. Obviously, it goes into great detail, but as an artist, he is considered the anatomical artist of the 20th century. So if you find one of these on eBay for a couple of bucks, I recommend picking it up. This is my second one that I have. I've had it for a couple of years now. But it does have some really great pictures. You guys always learn stuff. All right, let's see. Facet of flattened area, sharp projection of spine, cross set, okay. Trochanter, this is a unique one because this is found in the femur. Foramen. Foramen is a hole. Foramina, you'll hear as the plural. Meatus, it looks like meatus. It is pronounced meatus. You see that one on the bottom? It's a tuber tunnel, like it's an opening, is what it is. So it's not something that you just find in bone. It's something you find in other places. So make sure you understand what a meatus is. A sinus is a hollow cavity, a hollow space. Of course, we do have sinuses in our bones. Ossification is what we call it when we have that cartilage turning into bone. You know that when we're born, we have more bones than we do as adults, right? Does anyone not know that? Did you not know that? You knew that? Everyone knew this? You don't care? Okay. Why is it as children we have more bones?
They fuse when you get bigger.
Can you remove through the birth canal?
Well, it does, yes, because that would make everybody unpleasant. But what happens to those bones? Where do they go? Or those extra bones, where do they go?
They fuse together.
They fuse together. Right? So we have areas where it's cartilage that come together through a process of ossification, and they become bone. It's an important concept. It's important because when I watch America's Funniest Home Videos, and I see that drunken guy or girl on the table or bar, and they fall out off the table onto their butt, I don't think that's very funny, because I know all the fractures that are occurring, I know all the soft tissue injuries that are occurring. I don't see much humor in that at all. But when that little toddler takes a tumble down that hill, and then gets up at the bottom with that confused look on their face, that's hilarious. Because their bones are flexible, right? They have all that cartilage. Their bones are still partially cartilage, so they're made to bend. It's good for them because they fall over a lot. You know, learning to walk is a multi-step process, so that works out well for them. Bones grow longitudinally, et cetera, et cetera. That's boring. All right, we'll go through some boring. Osteoprogenitor cells are going to become any kind of cell that needs to become, okay? You've heard talk about stem cells, right? And people say, well, you get stem cells from umbilical blood or from embryos, etc. Realize throughout our body, we have a lot of cells that have the ability to become something else. I just mentioned the hematopoietic potential stem cells, right? When we have a fracture to this bone and we're going to want the bone to heal back together again, we have to fill in that space. And these are the cells that come in to fill in that space. We have them in our skin. We have germ cells in our skin that can become any of the cell that needs to become around it, including to a small extent something like skeletal muscle. So it can turn back, it can turn into that if it needs to. So this is kind of an important concept. You will still hear people who think that if you put a cast on a broken bone, that cast is there as some sort of magical power, has a medicinal purpose to make the bone grow again. And the reality is, why is that cast there?
Hold it still?
To stabilize it, that's it, yeah. Keep it in place so that the bone can regrow like it wants to. Because remember, if the body gets injured, it wants to put things back together. But they will think that can't take that cast off for another 6 hours. It's been on there 6 weeks, well, 5 weeks, 6 days, 20 hours. All right, osteoblasts. I already talked about these a little bit. These are the ones that are going to help build up bone, make sure that calcium goes where it needs to go. Osteocytes, these are the ones that are going to help collapse the bone at times when we need to increase calcium levels in the blood. These two specialized bones sound like they're working against each other. They sound like they're opposites, and they are. But that's just like glucagon and insulin. It's just like hot and cold water. They're working together, even though they're opposite, to get that right balance. But just like when you're in the shower and you got that right temperature and someone flushes the toilet, you have to make these sudden changes. The body does the same thing. Yes?
Are osteocytes and osteoclasts the same, or they have?
I'm sorry, osteoclast is a type of osteocyte.
Okay.
Yeah, sorry. It's the monocyte division is unclear. A monocyte is a type of red blood cell. Have you heard of these? Yes, no, maybe so.
No.
Okay. The monocyte division is still unclear how that can become any of the bone cells. They assume that it's coming from the same red marrow. They see that it doesn't leave. We see this with what other cells? A monocyte that can become a macrophage that does leave, that has the same sort of characteristics, but it just looks like it never left, it never became something else. All right, let me see. Anybody in here have a background in immunology? A background in white blood cell production? How the white blood cells are made? The different types of white blood cells? Lymphocytes are a type of leukocyte. There's an agranulocyte. Monocyte is a type of agranulocyte that becomes macrophages. Lymphocytes can become T cells or B cells. Monocytes become the cells that can go to other areas in the body, become, you heard of Cooper cells? Okay, specialized cells where they have a special place in the body where they defend. They go to that area, they become specialized for that area. It really makes sense if you think about you want to secure the perimeter of a building. The guy who's on guard duty, who comes on at 6 o'clock, he always goes out front this way. The other guy with the dog comes on at 6 o'clock, he goes to that way. The 3 guards go around to the side of the building, they always cover that area. The nice thing about having people who are specialized to an area is that if something changes, if something is different, if something doesn't belong, they recognize it quickly. Does that make sense? Okay. So that's what the monocytes do. They become tissue specific. And in that tissue, they can become the macrophage. They can become the large cell that can just sort of engulf a lot of things. So this is one that doesn't seem to leave. That makes sense? All of these cells start off in the bone marrow as hematopoietic pluripotent stem cells. They can then go down the agranulocyte line. They'll become one of those types of cells. And it becomes a monocyte that is either going to stay there, probably, or it's going to migrate out someplace else and specialize to the liver, specialize to the lung, specialize to the spleen, specialize to the skin. That's the idea. Is that a little bit clearer? Yes or no? Okay, it will be when we get to the immune system. It will be. All right, we'll get back to monocytes, macrophages, lymphocytes, all of the leukocytes. Intramembranous versus endochondral, ossification. I don't want to talk about that yet, that's boring. We'll come back to that. No. Which one's boring? Movements. Are you familiar with the movements? This will only take 5 or 6 minutes to get through, I hope, right? If you aren't familiar with these, you have to know these. This is the way terminology is going to be through your medical career. So it's important to know these things. Let's start off with an easy one. Flexion and extension. Flexion and extension would be something like bending an arm this way, decreasing the angle of the joint. Extending would be, of course, straightening the joint back out. Dorsiflexion and plantar flexion are important flexions for you guys to know. Dorsiflexion of the foot means what?
Pull it close to you.
Toes up, toes to the nose. Plantar flexion means
Shut down.
toes down, pointed down towards the plant. So, if my calf muscles contract and push me like this, which way are my toes pointed?
Down.
It's actually plantar flexing
Plantar.
my foot, right? Even though it looks like my toes are flat, I'm actually plantar flexing my foot. That's what's causing me to be up on my toes. Important that you understand that, because you will see this in the Babinski test. Have you heard of the Babinski? What is the Babinski?
Pediatric.
When the toes stand out during the like you take a thing and it like,
Take a thing,
I guess
yes.
like a pen or something, and if the toes stand out upward, then it means that response is good. But if you fan out, if you do it with an adult and they fan out, that's bad.
Yes, you're right.
I didn't articulate it very well.
Well, I think you got the gist. Bottom of the foot, the lateral edge of the foot, with something like a pen or a reflex hammer, you have the handle of a reflex hammer. You stroke up the foot from the heel to toe on the lateral side of the foot. What we want to see in an adult is we want to see the toes go down. That is normal. That is a negative Babinski. Normal is negative. If the toes fan up and out and spread out in an adult, that's a positive Babinski. That's bad. That indicates some sort of neurological, like spinal cord injury, for instance. However, in a child, it's reversed. You want to see this in a child. Up to about 18 months, it starts to switch over. Okay, so make sure you know about dorsiflexion and plantar flexion. You're going to see it. You might have to do it, but you'll definitely see an emergency room. You see doctors grabbing the person's foot and just stroking up the side of like this. All right, so that is important. Inversion, since we're on foot, since we're on feet. Inversion and eversion.
Inversions towards the midline.
Inversion is toward the midline. Like if you're walking down a curb and you're not paying attention, you step off the curb and your foot steps sideways, so your little toe is on the floor, it's on the ground. E version is the opposite. It's when your hallux is on the ground, your big toe, and your big toe's on the ground. That's E version. Now, why is that important? In trauma, somebody jumps out of a tree and lands like, somebody's playing basketball, jumps up and comes down on their foot this way. Why is that important?
That's suspected injuries.
You'll watch the person grab their leg here, and you think, well, their foot went this way. Why did they grab here? See the fibula runs up here? Notice the fibula does not articulate with the femur. The fibula articulates with the top of the tibia. So what ends up happening in an E version like this is that we end up with a proximal fracture of the fibula. The talus, one of the bones, the talus of the foot here, just shift and push this thing right up, and snap it right up here. So I think that happened to one of the college basketball players a year or so ago, 2 years ago. But when you see a person there screaming, grabbing their leg here, now you understand why. That's what an E version causes a proximal fracture of the fibula. Protraction, retraction, abduction, adduction. Have you heard of these? Abduction, adduction. You'll hear sometimes people say abduction and adduction, like I just said. Abduction and adduction, sometimes pronounced abduction and adduction. Since they sound so similar, sometimes we'll emphasize the first 2 letters, abduction and abduction. Abduction is moving a body part away from the midline, moving a body part away from the midline. Adduction, moving a body part toward the midline. Rotation, circumference, extension, flexion. Oh, hands, supination, pronation. Palm up, supination, supination, pronation, pronation. Supination, supination, pronation, pronation. If you don't know these by now, if you don't know these movements, please make sure you do. These are important. Notice with the extension, flexion. Flexion of the head, flexion is bending forward when the chin comes down further. Extension is head going back. So hyperextension, hyperflexion injury, what we call a whiplash. We'll see, we'll come back to that a little bit later on. I don't know why they give me this, I can't even access that. Okay. I really want to get through some of this stuff, that's why I'm skipping past this. I want to get through here and then we'll come back to some of these things. Because we've got some bones to cover, I want to make sure everybody's familiar with them, which means I want to make sure people are up here familiar with the bones. So what we'll do is we'll just have groups of people come up and I will point to a bone and you will describe it, demonstrate, or I will name the bone and you will demonstrate the bone to the rest of the class. After I go through them, of course. But I'm going to go through them quickly, because I'm assuming everybody has some sort of background, right? Okay. Skeleton is 2 main parts, axial and appendicular. Axial is the central components. Appendicular are all the bones that come off of that. Simply enough. And we'll start with the cranium. You will notice that when you look at a cranium that's been prosected, you'll notice that there is this cut here. Anybody know the name of this? This is calvarium. Yeah, this is made so the skull cap can come off, they take the brain out, right? Okay. So when you see it like this, there's a reason why there's always a cut right here. Looking at the skull, you can see the suture lines still here that separate the different bones. You can also see them on here, please ignore the worm bone. There's couple ones that I definitely want you to know about. The squamous suture is the one above the temporal bone. The frontal or coronal suture is the one that runs this way across the front. The sagittal suture is the one that runs right down the middle. And the lambdoid suture is the one that is triangular shaped, like is in lambda, Greek letter. Those are the most important. The bone right here in the front is the frontal bone, not surprisingly. We have these two mirror image bones separated by the sagittal suture. This is the parietal, right and left parietal bone. We have this bone right in the back here, the occipital bone. The occipital bone actually continues all the way into the cranium, right about to here. So this is all occipital bone. You'll notice in the occipital bone there is a giant hole. That giant hole is called the foramen magnum. The foramen magnum is important because that is where the spinal cord meets the brainstem, meets the brain. So it goes up through here. Of note, if you look at something like a dog's skull, where would you expect to find the foramen magnum? How about something like this, right? This is kind of important because even if you look at some of our close relatives, like the chimpanzees, even theirs isn't quite as far underneath as ours is. But when you look at some of those fossil records of early hominids, early man, you can kind of tell which ones are standing more upright and which ones are not. Interesting. Okay. Frontal bone, parietal bones, occipital bone with the foramen magnum. Off to the side here, we have the temporal bone. The temporal bone, you can see, has a giant hole right here. This hole, this indentation as it is where the bones of the middle ear sit. We have three tiny bones in our middle ear called the ossicles or the ossicular chain. The malleus, the incus, and the stapes, we'll see those later on. They sit in there. The right next to the right down here, part of the temporal bone, you see this big jutted process. You can feel this right back here behind your ear. That is the mastoid process. That's an important connection for the muscle that stems from our chest up here that helps to bend our neck towards the center. In front of that, there's a little spike called the styloid process. Then we have the sphenoid bone right on the side. Now the thing about the sphenoid bone is if you look at it from the side, look at it here on the drawing, it looks like just a sort of a rectangular bone right here. Makes up part of the eye socket, you would think, or the back part of the eye socket, it looks like. The reality is this bone stretches all the way across. And it looks actually more like a butterfly or a saddle, a horse's saddle. It's important because it has some very interesting and unique features that you need to know about. Part of it is the ethmoid bone. Part of it is a little depression called the sella turcica, where the pituitary gland sits. I think that's all for right now. Yeah, okay. I was going to say that it also has a cribriform plate, which is where the nerves for sense of smell come through, but you don't know that. All right, the cheekbone right here. The cheekbone actually is this area right here. It is not this whole part. Because this part right here is also temporal bone. The temporal bone actually stretches across towards the cheek. It stops right here. And then from that point on, right to here, we have the zygomatic bone, zygomatic. That comes up to the maxilla. The maxilla, of course, is the bone that holds the upper teeth. Above that, we have the small nasal bones. We also have the lacrimal bones right inside the eye sockets. Again, I'm not going to hold you responsible for those, but I think they have them in the book. In the middle, we have the vomer. Let's see. Okay, you can see vomer there. You can see it. wasn't sure if you can see it in that picture. The bone was sort of this plow-shaped bone, this very thin little plow-shaped bone right down the nose. We have the only movable bone in the cranium, the mandible. Underneath, you can see the very large hole right here, where the jugular vein comes out of the cranium, the jugular frame. And another one that I always include when I talk about the cranium is this bone right here, even though it's not in the cranium. This bone right here is called the hyoid. The hyoid. The hyoid is important because it's, first of all, it's the only bone in the body that does not articulate with another bone. Every other bone articulates. This one does not. It just sort of floats off in space. And this helps to support the larynx. Where the vocal cords are, it's just above that. The laryngeal cartilage is slightly below it, where we find the laryngeal prominence, which is, of course, in men, you can see and feel that obviously is the Adam's apple. All right, so what do we do? Frontal bone, parietal bone, occipital bone, foramen magnum, temporal bone, mastoid process, styloid process, the sphenoid bone, the zygomatic bone, the nasal bones, the vomer, the lacrimal bones, the maxilla, the mandible, and the hyoid. Right? Right. And we included external auditory canal, right? Okay. I think that's good for now. We'll take 10 minutes, we'll come back, and we're going to go through more of the skeleton.